have another speaker, Shail Vasavada, who will be presenting on optical biometer with image guiding. So the next one will be 4. Are you clear? Yeah. He's not here.
Okay, hard.
So if so, then Chaudhary, then Prakash.
So, very good evening. I'll be sharing something that is now becoming a part and parcel of any routine cataract workup, the optical biometer, and how it has helped to improve our outcomes. And I acknowledge Dr. Vaishali Vasavada's presentation here. So the goal of cataract surgery now is getting more and more into a refractive cataract surgery and not just achieving a clear cornea on day one. And therefore, if we need to be more and more closer to less than plus or minus 0.5 diopters, we need several of the power calculation parameters for getting an accurate that includes accurate keratometry, axial length, chamber depth, lens thickness, wide to wide, because all of these, the more data you have, the better you can predict the effective lens position post-operatively, which will determine the refractive outcome. Amongst the contribution of different parameters to post-operative refractive error, Dr. Olson showed in his study that actually the measurement of ACD, axial length, and keratometry, these three parameters still have the highest incidence of causing post-operative refractive surprise if not measured accurately. We did our own study when we acquired our first web source OCT, which was TOMI, and we compared it with the LensStar, and what we found was that the LensStar could capture axial length only in about 82 to 84% of eyes, whereas the swept source based OCT could capture in almost 100% of eyes, 98% of eyes. So except for that extreme wide cataract where nothing can go through, the swept source generation OCT biometers are doing very well. We all now have access to several different instruments which are helping us to improve our outcomes, but it is also increasing the time taken for the patient to go through several different instruments. So therefore, we all are looking for instruments which are fast, which are reliable, which are accurate, and which can do more than one thing in one capture. So therefore, it needs to be more patient-friendly, and I think particularly with the Argos with which we have now significant experience, not only do we get the advantage of getting a very fast and reliable swept source OCT-based capture, which means the axial length and other things are captured very fast, but also at that same time we are able to capture the digital image photograph of this patient, which is going to help us in toric IOL planning as well as toric IOL placement. There have been several studies done comparing these different forms of swept source OCT biometers, and all of them do very well as far as capturing the axial length goes. But the Argos has a slight edge as far as penetration and achieving even more higher percentage of axial length in very, very dense cataracts. And fortunately, it also has access to all the standard, commonly used, popular, very accurate formulas like the Barrett and the entire Barrett suite, including the Barrett True-K as well as the post-refractive and the toric calculator. So how does it really matter in a clinical practice? This was an ophthalmologist, a 74-year-old, black cataract, very, very keen, delayed cataract surgery out of fear for many years, but now very, very keen for a trifocal IOL. Unfortunately, no axial length could be captured with the OCLI-based optical biometer, which was the LensStar in this case. But for the swept source, with the swept source, we were able to capture the axial length very accurately, no red flags, and therefore we were more confident with our IOL power calculations, and therefore it helped us to achieve a good outcome post-operatively. how it helps to reduce the possible refractive surprises. So this was a 33-year-old female, dense development cataract, has read about everything, does not want trifocals, and she is very keen on having an extended depth of IOL, the Vivity IOL in her case. Once again, unfortunately, due to the dense cortical and posterior subcapsular cataract, we were unable to capture the axial length with the lens star. And therefore, we went ahead and did the immersion biometry for her, and the spikes and everything were reasonably good. And we've had good experience with immersion over the years. So we went ahead with the calculation based on the 24.63 axial length that the patient had measured on the immersion. Surgery went off very well, and post-operatively very quiet eye, clear cornea next day. But the patient ended up with a refractive surprise of 1.5 diopters on the myopic side. So when we now, once the pseudophakia was achieved, when we measured the axial length again on the lens star, what we found was that the actual axial length was 25.36, which we erroneously measured at 24.63. So if we had access to the swept source biometer at that point of time, probably we could have avoided this refractive surprise from occurring. Another very important point is that the toric calculator in most of them is now inbuilt, which means you don't need to actually go online all the time to calculate. Because we have realized that just relying on the difference between K1 K2 is not enough. Say for example, in this case, the difference between K1 K2 is hardly 0.35 diopters. And in a normal situation, if you think of it, for 0.3, 0.4, would you even think of considering a toric IOL? But when we put these values in the calculator, and this is because the steep axis is vertical, it adds up, and therefore this patient actually required a T2 IOL. So many of our patients where we feel, everything went off well and he's now ended up with 0.751 diopter, that's because we are not calculating for all eyes, and it's also because it's cumbersome to calculate for each eye going into the laptop or into the data set. So therefore, if you have an inbuilt toric planner inbuilt to it, with your capture, it will also tell you whether this patient requires a toric IOL or not, and therefore you can counsel them accordingly for the same. This is a review that we have recently put into peer review and should be out very soon, comparing the difference in the ocular biometry parameters, comparing various swept source-based OCT biometers, which include the commonly used IOL Master 700, Anterion, OA 2000, Argos, and the iStar by Harkstride. And based on this entire meta-analysis review, what we found was that the Argos had a highest, one of the highest acquisition rates in literature of achieving axial length measurements more accurately and in a higher percentage of eyes. It's not only a great tool for patients, but it's also a great tool for surgeons intraoperatively as well. Because now with more and more toric IOLs being done, this is something that is very, very common. You do everything right, but the marking goes haywire, it blotches up. You dried up everything, but methyl cellulose came up from the fornices. Also, preoperative marking is not as accurate as we presume it is to be. Take for example this case where the patient had a good 2 diopters of astigmatism, very regular bow tie astigmatism, and we did a 16 diopter toric IOL, and the patient ended up with 4 diopter cylinders. So we went immediately and looked for the placement. Calculation showed 64. Placement was roughly around 64-65 degrees. Then why did this patient end up with a high astigmatism? And that's because there was a transcription error, which means we fed the steep as the flat and flat as the steep when we went online and did the calculation. So this is human error which can creep in when there are multiple cases being done. And if that human error or that transcription error is taken out, we can at least avoid these embarrassing situations from occurring. Not only does it help in IOL placement, I think this is the most important step which I find useful with image guidance is performing a perfect capsulorhexis. We do all have access to flags, many of us do have access to flags, but using this guide, which is a dynamic guide, helps us to achieve a good centered capsulorhexis of an appropriate size based on the eye to eye. If it's a myopic eye, we may do a smaller rhexis, and it also helps us to place the IOL appropriately in its position without having the hassles of marking. So it can be relied upon as a standalone device for all your IL-PAR planning, calculation, for toric calculation, as well as intra-op assessment. So thank you so very much for the patient listening.
Thank you, Dr. Vaishali Vasavada. A nice presentation regarding all